to another episode of Checkup with Bluegrass. I'm Bruce Tossan, Interim CEO and Market President here at Bluegrass Community Hospital. Each month, we bring you conversations with healthcare leaders and providers who are making a difference in the health of our community. Today, I'm joined by two members of the Central Kentucky Pain and Spine team, Dr. Vinod Minaswamy, an interventionalist pain physician, and physician assistant Daniel Baker. September is Pain Awareness Month, and we'll be talking about the role of pain management in improving quality of life for patients across our region. Dr. Minaswamy, let's start with you. Many people hear pain management and think of medications, but I know what you and your team provide goes far beyond that. Can you tell us about the type of care offered at Central Kentucky Pain and Spine?
Sure. Good morning. Yes, for decades together, there's always been this practice where a patient like you and like him and like me go to a doctor and then we talk about a pain and they start you on pain medications because that was the only tool in the box at that point. They started oral pain medications. Then the patient comes back in 10 days and says the pain is not better. They increase the medication, and finally, decades later, where are we? We are in an opioid crisis right now. That's exactly where we are, which is why a field like mine, which is interventional pain, has taken a new dimension, as coming to the as a rescue to this entire catastrophe that has happened, where we come and we figure out what's the reason for the pain and provide a lot of solutions, including therapy, interventions, minimally invasive procedures to help with the pain. So pain management, yes, there is a place for pain medication. Yes, there is a place for pain medication. When everything fails, when then there is a place for pain medication where it helps the patients and it helps a lot of patients with several different kinds of diagnoses. But with pain management doesn't mean only oral medications. Oral medications is now the last resort. You have everything else in place to take care of it. As I said, and I will repeat again, therapy, interventions, procedures, minimally invasive procedures, and change in lifestyle, and figuring out what caused it, how to prevent it, and that will be a big aspect of the pain. So having said that, pain management is not pain medication. It's interventional pain where we figure out interventions, including therapy and procedures.
Kind of like a holistic approach.
Yes, it is a holistic approach. Yes.
Daniel, as a physician assistant, you work closely with patients through their treatment journey. What are some of the most common conditions you see, and how do you help patients manage them?
So, when I first joined interventional pain, of course, I didn't really know what it was, but everyone thinks, chronic pain, they think back pain. Which is, of course, a big part of what we do every day. I mean, we see every day. Most patients have some back pain, but what's fascinating with this space and what's really exciting about it is there's so many things that patients deal with daily that kind of goes secondary. They talk about their back pain, they live with it, but they also have other pain. I mean, you'll talk to patients and you walk in the room and they're wearing sunglasses and the lights are out and you talk about their back pain and you're like, what's going on? And they're like, well, I have headaches. And you'll ask them, well, what do you do for your headache? And they're like, oh, I talked to my primary care about it, like I'm here for back pain. But that's one thing we want to be very open and welcoming about is we want to look at that patient and say, you're here, we're here to tease out whatever is going on with you. That's something him and I both try to do every day, no matter what we're seeing. We're saying, okay, I see, you have a brace on your knee. What's going on with that? Because we're treating head to toe. I say that, but it really is true. I say any muscle, joint, nerve, ligament in the body that bothers you, we're able to do something for it, as he already spoke about. I mean, there's the conservative approaches and non-invasive interventional procedures, but there's also a lot of options that patients don't know about. Even primary care physicians sometimes they treat the patient as whatever that they were taught in school to do, but there's so many new things out there, and that's what's exciting. So anything head to toe, we're treating lumbar degenerative disc disease is one of our big complaints, low back pain. But migraine, headache, as I spoke about, arthritis, and how many joints do we have in the body?
Yeah.
Any joint we can do an injection for, basically. Nerves, nerve blocks for, patients will say, well, my leg, it just has this weird sensation, feeling, and they just ignore it, and they've accepted to live with it. And I think that's what's cool about our space is we have an option that they don't have to just live with it and ignore it. So that's what gets us up every day and excited to go to work.
Very interesting. You're starting to make me feel all my pains. Dr. Minaswamy, pain can be such a personal and life-altering challenge. What's your approach to helping patients who may have been struggling for years without relief?
It is true. Pain aspects every aspect of life, from psychological aspect of depression, anxiety, to relationships and everyday life, and leading to immobility, causing obesity, and causing more pain. Pain does affect every part of life, and patients have lived in this for years because patients have always been doing the same thing they were always doing. Going back and trying to think about Tylenol, ibuprofen, medications. And this has led them to the space where they think, okay, we can't do anything. I've tried everything. Well, most of the time when I see patients, I've tried everything. It's not helping. What have you tried? I've tried Tylenol. I've tried ibuprofen. I've tried this medication, that medication. I'm like, all right, have you tried lifestyle changes? Have you tried? We get into the depth of it. That's what we do. We look around the room here, and we have a beautiful team, where we sit and take time with the patient and see, all right, 20 years you've been on this medication. Your pain has been the same thing, right? Your day goes by waiting for that 8 hours to take the medication. Your life revolves around the medication part of it. So most of the time when I see patients and they say, I've had my life changed, all my life I've been dealing with this pain, they have basically lived their life around the pain medication, trying to manage their life, which is not wrong, which is what they've done, which they've been taught. But we take time when the patient come to figure out what is really causing the pain, what are the different aspects of pain, what else, other facets of life has it affected your the psychological, then we talk about pain psychology, we talk about things like that, coping mechanisms, cognitive behavioral therapy, all those aspects come into play. So we sit and take time and figure out how we can be helpful in a multidimensional way rather than single. You come here, you get an injection, you come here, you get cut, and then things like that. So we do take time and sit and discuss about these things and try to come out. Most of the time, we are extremely successful in always making the patient walk out with a smile even after the first interview, giving them the options and making them think in the ways that they've not thought about. And that itself is a whole lot for the patients because they've been heard for the first time in a long time about their pain and about how we can manage this and how we can treat it.
So a big piece of education of all the opportunities, alternatives, as you said, the tools in the toolbox.
That is true. Education is the key for everything. I tell my 2.5-year-old the same thing. I tell my 80-year-old mom the same thing. Education is the biggest aspect of everything. We do everything wrong in life only because we are not knowledgeable about it or not educated about it.
Excellent. Just as a follow-up, many of our listeners may not realize that pain management can involve advanced procedures. Could you share a few examples of the interventional techniques you use, like injections or spinal procedures, and how they can change a patient's day-to-day life?
Yes. I always tell this to the patients. I always start pretty much my interviews saying that in a small area as much as a fist in your low back, there are 60 different things that can cause pain. Trying to examine and figuring out what the pain is, where the pain is coming out. Is it one, or you got to tease out the most likely reason you pick out and start eliminating that cause one by one and figuring out the pain. So to tackle the 60 different things that can cause pain, we have developed several techniques. And when I say we, I did not develop it, but there are several skills around the world which we have encompassed in our practice, where we figure out what is actually causing the pain, how can this pain be managed without even touching the patient, without even putting a needle in the patient. We try to is it just a simple lifestyle change? Is it just the smoking habit that has to change? Is it simple getting up and doing things rather than going through a drive-through all the time? Those are the different things that we start off with, and then we get into if the normal change in the behavior and normal change in lifestyle has not worked, then we have several tools in our which includes minimal minor injections, minor therapies, minor injections. Even without injecting, even without it being invasive, there are several of the instruments and things that we can use without having to get into the without it being invasive to control the pain. If those fails, then we get into procedures, minor procedures like minimal amount of injections to control the pain for a longer time. The goal is not to keep injecting them every month or every 10 days. The goal is to one injection can take it all. That's the great thing to do, and that's what we need to do. And that's what we do in our department. So we talk about several injections, like it could be as simple as epidurals, it could be as simple as a simple muscle injection, a ligament injection, trying to figure out around the ligament if there's something causing pain. Is it a disc? Is it the bone itself that's causing the problem, or is it the joint that's causing the problem? So those are the things that figure out, and we have procedures like nerve blocks, radio frequency ablation is a big thing. If all of those things fail, then we have minimally invasive procedures like spinal cord stimulators, intrathecal pain pumps, spinal fusions, endoscopic discectomy. So several procedures like that we can do, which does not involve an incision in your back, which is as big as I would say 10-foot incision. As people walk into my clinic and say, "What did you have discectomy? What level?" 1 level, and I look at the scar. It's 10 centimeters scar. So there are ways that patients don't have to be cut unnecessarily. So figuring out the minimally invasive thing that we can do, and we have several techniques, as I told you. I will not go into the names of each technique, but there are several techniques that we can do, which is minimally invasive, including joints, nerves, muscles, tendons, and spinal cord.
Excellent. Daniel, patient education is often just as important as treatment itself. How do you and the team help patients understand their condition and take an active role in their recovery?
Yeah, when a patient walks in and they tell you their complaint, you can pretty much, or you hope that they didn't get on Google too much, but it's kind of our duty, our job to really explain why the pain's there, like what is going on, because you just wouldn't believe how many patients they've had shoulder pain or they've had knee pain or back pain, and it's been very much summarized as it's this pain, and we'll give you, we'll do a shot, or somewhere else may have told them that, or we'll write this medicine, and then it's pretty much, that's the visit. So, I mean, I think something that, he taught me early on, and something we try to instill every day, is we want to look at the images. We want to see, what is the pathology there, because as with anything, the more you understand about something, the better equipped you are to actually fix it. You take your car to the shop and they'll charge you $1,000, and you hope you're paying to get the real problem fixed. It's very similar with what we do. These patients, they come to us, and it takes a lot for them to get there. Whether it's the transportation, the financially, or even just the courage to come into our office. So it is our responsibility to sit with them, talk about, really, like he said, examine them well, look at the imaging, and decide what is the most likely cause. What are we dealing with here? And then we make a decision through that encounter and offer them their input too, because culturally, the patient, patients come to us and they want options,
right.
And that's really what we want to do. So with patient education in mind, I'm in any given day, I'm picking up a marker, I'm writing on a board. I saw him doing that when I started with him, and I think we both do that all day. The pictures are not good, but it's enough to kind of explain in layman terms what is going on with the patient, and we're using models and demos to show why they feel the way they feel. And I think a big part with patient education, as with anything, is in a way just being able to inspire. Once a patient knows, oh, I've been doing this for 30 years and I'm getting the same result. Maybe I need to, actively make a change somewhere, and that's where you get into the lifestyle and the behavior changes. But just kind of equipping them, giving them the tools, giving them the resources, giving them the I guess the confidence sometimes to just to try PT again. They say, well, I've went to PT, and we all have, but just saying, we'll try this injection. Maybe your pain will be better controlled. So this time PT will look different for you, and just explain to them that they're not making this up. It's a real thing. The pain is and the underlying disease process. So if we can get right at that disease process, their outcome is going to be much better.
Right, and not a cookie cutter approach.
No, exactly.
It's
very
individualized.
Tailored. Yes.
Awesome. Dr. Muniswamy, you worked in Versailles and Georgetown for several years. What makes practicing in these communities special for you?
I love this question because I'm a big city guy. I come from a big city in my past life, and I love to live in big cities. But several years back, almost 15, 20 years back, when I made this decision of staying in this place, I remember I was finishing up my fellowship, and my wife pretty much said, "This is the radius you need to search a job in because I want to live in this house where we are living." And I said, "All right, let me look around." And then I remember driving around the city, and I figuring out the city is actually populated than what I think it is. Let me go a little bit outside the city and look at it. And then when I came to Versailles and looked at Georgetown, that was the place itself was so calm and so beautiful that I loved the place. And I'm like, all right, there is something I can offer with my expertise here, where patients from here don't have to go into the city and struggle and get treatments what they can get here itself. The people of, I'll tell you, the community of Georgetown and Versailles, they are highly respectable patients who require the highest level of care that they need to get. These are the patients. These are the people who have worked hard all their life, taken care, and made Bluegrass such a beautiful place only because of Versailles and places like Versailles and Georgetown. And these people deserve the best. And when I started practicing here, and when I started realizing that patients have not been given these options, I realized that the patients needed to hear more and more. And these patients are so receptive, they're so respectful. They listen to what you say and what you offer them, and they do the right thing, which is why I love practicing in Versailles and Georgetown, because it's now my home. If anyone asks me now, which is your home, this is my home. I love where it is. I love the people here. They're extremely modest, very hardworking people who live their life working hard. And now it's my time to take care of their pain.
And they're so appreciative of what you're doing for them.
Yeah, they are extremely appreciative of everything that we do. Every day, money comes and goes, but every time the patient walks over and tells me, I love this place. This is the first time I heard my doctor talking to me. I love that. And I give the time only because they deserve it. And these patients are really great.
Awesome. Daniel, chronic pain doesn't just affect the body. It impacts mental health, relationships, and even a person's job. How does your team address the whole patient, not just the physical symptoms?
Yeah, good question. So yeah, as we've spoke about, chronic pain is multifactorial, multidimensional. These patients, they come in, and it's not one issue that brought them to our office, right? So I think just meeting them where they are, we try to collaborate with their primary care physicians. Every visit, before he sees the patient, if they were a referral, he's looking at the notes, where their history, which sounds really simple, but these patients usually, by the time they get to interventional pain, unfortunately, there's a long history there, and a lot to read, and a lot of things have been done or not done. So, you kind of have to take that into consideration. Sometimes these patients, they get to us and they're frustrated. Sometimes they're very happy to see us, but sometimes they're frustrated, and not just frustrated in like they're mad. They're exhausted, mentally wore out, not just with the pain itself, but also the process of healthcare. They've done this, they've jumped through, they say this often, I've jumped through a lot of hoops. which is very true, you know, and it's a lot for me. I'm 34 years old, and I feel like sometimes jumping through hoops is pretty difficult. So you take that into account for someone that's, you know, twice my age and lived, you know, worked really hard their whole life. You know, it's something that I want to sit down and say, okay, let's rest a minute. You're in the right place. We're not going to try to put you through more than we need. And I think that's what's cool with our space. You know, we're trying to take into account if someone has pain. Yes, there is the pain, but pain isn't the only thing. It's the function part, and that's where this really kind of comes full circle. Is if you're looking at that patient and not treating them comprehensively, you're almost destined, or they're almost destined to not have a good outcome. You really have to take into account, you know, they have jobs, they have grandkids they got to take care of, they have a lot to do, and the pain that really, if they could do what they wanted to do, they would do it. Right. It's the pain that's preventing them. They'll ignore. How would I say that? I would say that the pain, they'll push through the pain. It's that they functionally can't do what they want to do, and that's really, you know, looking at how they walk into our office. You know, if they're struggling, then, you know, we kind of take it as, again, our duty to offer something to them. And I think, you know, you look at these patients that, as he's already mentioned, they have relied some on opioids for years. And I think when you don't treat the patient holistically, it's very easy to look at the patient and say, you have back pain, try this, and we'll talk in a month. When you look at the patient holistically and you look at their history, and they have, you know, they express their concerns. Maybe they have a family history of drug abuse. They don't want opioids. You know, they're not even asking for it. So, you know, you have to take that into account. Maybe they, again, maybe financially interventions aren't a good option because they can't afford it. So we have to take that into account. So many times these patients are kind of between a rock and a hard place, and that's where, you know, if you don't look at them holistically and you just jump to the first thing or the easiest thing, you're destined for a poor outcome. And, you know, people say, you know, pain is the symptom, but, you know, there is a disease there. So I think you have to get at that disease to ever really make a positive change for that patient, because ultimately at the end of the day, you know, the patient-centered care, like we say, that's really what it is. You know, if it was centered around what Dr. Muthuswamy and I wanted, you know, yeah, there's certain days, you know, it's hard being a provider, but we have to really kind of put ourselves in their shoes to really kind of understand where they're coming from, and I think that really gets at you know, the whole heart of community health.
Excellent point. Daniel, one more. You and Dr. Muthuswamy sees patients in multiple locations, including Georgetown, Versailles, and Paris. Can you talk about how expanding access to care helps patients in our region who might otherwise have to travel long distances?
Yeah, I think I look back when I was younger. Of course, I grew up in a small town, London, Kentucky, about an hour and a half from here. And I remember as a child, of course, both my grandparents were veterans. So it was very common that we would drive to Lexington to take the grandparents to their doctor's appointment. And, you know, it was never a time where it was just like, oh, we want to go to Lexington. That was where we had to go, or where they had to go. And, you know, I grew up, countless appointments I would ride with my parents taking them. And, you know, it's, yes, it would be fun. We would, you know, get out of London a bit. But, you know, you look at these patients and what they go through, just even getting up to brush their teeth and to get clothed. It's a big process. It's a big burden on them and their families, and coordinating appointments and making sure there's child care while they take their grandparent for a procedure. There's a lot of people involved in this. So, you know, when I think about our locations, which are, you know, very, very much like surrounding Lexington, which is some of the most beautiful, in my opinion, some of the most beautiful land in the country. You know, Central Kentucky, Life Point, Bluegrass being one of the facilities. You know, you look at, like, what is our mission? Well, making communities healthier. I mean, that's really the whole goal of this. Right. So that's the only way to really to help the people in the community is we have to make this accessible, affordable, and really equitable for all. And the only way we can do that is to position ourselves in the communities where these patients need us. And I just think it's really cool, that patients that have been getting procedures done in Lexington for years, now, their primary care physician sends to Dr. Muaswamy, and they're like, you do these here? And it is, it's amazing, these procedures, which, for him are, very, bread and butter things that he was trained to do, and people drive, an hour to get that procedure, and now we can do that here, and they can be here in 10 minutes, get the procedure, and they're home, and it's just really cool, and I'm excited for where that's we're adding more and more procedures. So even minimally invasive spine surgeries, which you would have to go to an advanced subspecialist, maybe even in a bigger city than Lexington, and sometimes, and we're doing this here. So I think it's a great opportunity for us in this space, but also for the patients ultimately, which is what matters most.
The beauty of having care closer to home.
Yes.
Dr. Muaswamy, this is our final question. Yep. For patients listening today who might be nervous about reaching out, maybe they're just living with pain for years, what would you say to encourage them to take the first step?
Yes. Most of the patients that I know have lived in pain for years. But I want to tell you a little bit about the background from where we are. I come from a medical system where getting an X-ray is a luxury. So I come from a medical system where I have to listen to the patient, touch the patient, examine the patient, come up with my diagnosis, and treat the patient. If the treatment does not work, then we go out of the way and do a luxurious thing as to get a simple X-ray to see what the problem was. So the training has been so robust, and from where I am, that it depended mostly on listening to the patient, examining to the patient, and then formulating a plan before you get any imaging services, before you so that you don't jump into conclusions. After that, I had some training in a little bit of training in orthopedics, and then I've come to this beautiful country, and my basic training was in physical medicine and rehab. And then while I saw patients of my in physical medicine and rehab having so much of pain, I went and specialized myself in pain so that I can have a comprehensive look on this entire pain system, so that I can help patients in every aspect of life. Whether it's got to do anything with the orthopedic issue, or whether it's a physical issue, something that needs a simple rehab issue, or something that needs an interventional pain issue. So I want to tell the patients who are listening carefully that when you come into our facility, you will have a comprehensive care. You will be heard. You will be examined detailedly, and then and discuss with the most appropriate plan and least invasive plan that we can come up with that can help you have a better life and better quality of life. I know that you lived in pain for long. I know that it has taken a toll on every aspect of your life. But here we are here to sit and listen and fix the problem so that we can make you have a better for the rest. We can make you better for the rest of your life. We have a beautiful team, as I always tell, and everybody has got the same ethics, and we do the same thing. Pain doesn't mean you need to be cut on. Your surgery is not the answer for everything. There's a lot of things that can be done without surgery, and do not land up in a place which requires only surgery for you. Back pain, knee pain, shoulder pain doesn't mean surgery. There's a lot of things that can be done before orthopedics that can avoid going into surgery and never have to go into surgery ever. So that's what I want to tell you. You will be heard, you will be examined, you will be given the right appropriate choices so that it can be taken care of.
Thank you.
Thank you.
It's clear that Central Kentucky Pain and Spine is bringing much needed relief and hope to patients across our region. Dr. Muaswamy and Daniel, thank you for the work you do and for joining us today. For our listeners, if you or someone you know is living with chronic pain, give this team a call at Central Kentucky Pain and Spine. That's all for this month's episode of Check Up with Bluegrass. I'm Bruce Tossin. Thank you for listening, and we'll see you next time.
Thank you.